Hey guys, it's Jean Marie. I'm going to be talking today about thyroid and parathyroid gland problems. I apologize for not getting this up yesterday. I lost my voice and was not able to finish recording. Here are your student learning outcomes that we'll be working with today. Hyperthyroidism, it's an increased metabolic, causes an increased metabolic rate, increases sympathetic nervous system. Remember, that's your fight or flight in all body organs. Hyperthyroidism has many causes. The most common cause is Graves' disease, which is an autoimmune disorder resulting from Hashimoto's syndrome, which is a result in the production of autoantibodies to different substances and structures within the thyroid gland. In Graves' disease, these antibodies, they attach to the thyroid stimulating hormones, and because of that, it increases the number of glandular cells, and by that, it causes the goiter that you'll see on the thyroid glands, and then this overproduces the thyroid hormones. Graves' disease is the most common type of hyperthyroidism. There are two general things that occur with this disease. You have the ectothalamus, which you see here in the picture, where they have the over protruding eyes, and they also have pretibial maxilledema, which is a dry, waxy swelling in the front of the leg, and they look almost like keloids or like little fatty tumors. You see a picture of that here as well. And remember that maxilledema, we'll talk about it in just a little bit, but that isn't just fluid, it also has some tissue in it, so it's a thicker type of edema. When we're doing our assessment looking at hyperthyroidism, we want to make sure that we record their age, gender, and any unusual weight loss issues. Because of that increased metabolic rate, will affect their nutrition. You'll see weight loss. Sometimes you see diarrhea. There's a list of key features of hyperthyroidism in chart 63-1, which does a really good job. But you also see the goiter. Now, the goiter in this picture here, right there, if you look at it, you can see that that's pretty significant. Most of them are not that significant. They're caught earlier than that. These people have a lot of problems with anxiety, excuse me. They have a lot of excessive sweating and they're abnormally warm. It's almost like you have a 20-year-old woman who all of a sudden is acting menopausal because she's having these severe hot flashes, and they're a lot of times much warmer than the average person would be. They're abnormally hot. Nursing interventions that you want to make sure that you keep an eye out with hyperthyroidism is because of the thalamus and the eyelid retraction. You want to make sure that they have eye protection, make sure that they have drops to their eyes, because their eyelids protruding will cause corneal ulcers. So we need to make sure that these patients are vision is being cared for as well. Diagnostic testing for hyperthyroidism is measurements of blood levels of the T3 and T4 and TSH, and the antibodies to the TSH receptors are measured for the diagnosis of Graves' disease. The most common changes in laboratory tests for hyperthyroidism are listed in that table or chart 63-2. I don't expect you to know those. Just know for our intents purposes that lab work is done to for the diagnosis of Graves' disease. Other things that we may do is a thyroid scan. A lot of times these people, it's because of their psychosocial irritability. A lot of times their family notices something's going wrong before the patient themselves do. Most of these patients are treated non-surgically. For nursing interventions, though, we want to make sure that we're monitoring their vital signs and make sure that our unlicensed personnel realize that even a 1-degree alteration in their temperature can be a sign of impending thyroid storm, and it's important to report that to the nurse, and in turn it's our responsibility to report that to the provider. A lot of times these patients request or need decreased stimuli. They need to have their comfort promoted. The room may need to be cooler than most other patients' rooms would need to be. As far as non-surgical therapies, there are drugs that will block the thyroid hormone production by preventing iodine binding and delayed responses. Sometimes these patients also will have radioactive iodine therapy that destroys overactive cells over 6 to 8 weeks. This is usually outpatient and is close monitoring. And like with any radiation activity, it stays in their body much longer, and they have to take radiation precautions, which are listed for us on 63-4. Surgical management, again, is reserved for the most severe cases or for cases that do not respond to non-surgical management. Pre-op, they'll be on a high protein, high carb diet. Afterwards, like with any surgical patient, you want to make sure that you're helping with that pulmonary hygiene or pulmonary toilet, where you're making sure they're coughing up their secretions. They'll have a neck dressing and usually a drain. So you want to observe for bleeding and for sources of infection. They'll also be hoarse, and that'll be expected for a few days. And you also want to make sure that you're watching for signs of hypothyroidism. Post-operative monitoring, of course, we're going to monitor for hemorrhage, which is most likely going to occur in that first 24-hour period. They also may have laryngeal stridor, which is that singy respirations due to an acute respiratory obstruction, which would be a medical emergency. You also are still monitoring for thyroid storm, so you're still taking that temperature more frequently and looking for even that 1 degree change. And that, again, is would move them into the critical care realm, which would move them into 495. You want to make sure that you're keeping an eye on that suture line to make sure that the dressing's not too tight and you're not having increased edema. The main thing to know about thyroid storm is that it's a medical emergency, so we want to make sure that we are looking out for it. So we're looking for that increased temperature, we're looking for increased blood pressure, increased heart rate, and these would be signs to call the provider or a rapid response team so that this patient can be treated in a critical care environment. Hypothyroidism is the low level of thyroid hormones, causes decrease in metabolism, stimulates the anti-pituitary gland to increase TSH to try to stimulate the thyroid gland. You see enlargement of the gland forming a goiter. The thyroid function does not increase though. The cellular energy decrease causing a build up of metabolites, and this increased mucus and water causes cellular edema, and that's again that maxilledema. It's a different type of edema because it has that mucus portion in it as well as the water. There are many causes of hypothyroidism, and it is a very slow onset. For hypothyroidism, again, their assessment is going to look opposite of the patient with hyperthyroidism. This patient's going to have bradycardia, hypotension. They're going to have cold intolerance. They're going to have lower body temperatures. They're going to have weight gain. They may sleep extensive hours. They're just the exact opposite of those patients with the hyperthyroidism, and they're listed on chart 63-6. Again, diagnostics are still done with the T3 and T4. This time, though, they'll be decreased, and their TSH is elevated. Along the interventions for this is lifelong replacement therapy. Big nursing intervention here is, again, patient teaching for their drug medications to make sure they're taking them at the same time every day on an empty stomach. Again, one of the major nursing interventions with hypothyroidism is make sure that they are taking their medication at the same time every day and on an empty stomach. Most of the time, these patients take this medication prior to breakfast. Again, your patient with hypothyroidism is your exact opposite of your hyperthyroidism. These patients are freezing even when it's warm out. Again, our major nursing intervention with these patients are making sure that they take their medication at the same time every day on an empty stomach. Here with the maxilloma, it's again the exact opposite of a thyroid storm. This is what you see with patients. This is the severe hypothyroidism. For our purposes in this course, I want us to think like we're working on a medical surgical unit and think of 495 as your critical care units. It's still very important for those nurses on the medical surgical unit to be able to recognize patients who are leading up to having problems. So that's what I want us to look at here. So the majority of what I want you to look at is things that you would want to report to your provider. You want to make sure that if all of a sudden saw this patient with lower blood pressure, you got their morning labs back and they had low sodium levels, their temperature was unusually cold and it had already been rechecked, they had a low blood sugar. These are things you would want to notify the provider about immediately, and obtain meaning to get or gather in order to have care transferred into a critical care unit. We're just going to talk briefly about thyroiditis. It is inflammation of the thyroid gland. You see acute, you see chronic, which is Hashimoto's disease. Of course, we know that Hashimoto's disease can lead to Graves' disease in hyperthyroidism. And that is the most common type. So a lot of times these patients will have the inflammation of the thyroid gland, and that's when they are diagnosed with the Hashimoto's disease. But remember, it can be acute, which is bacterial or viral, but usually it's chronic, which is from the Hashimoto's disease. Briefly about thyroid cancers. Prognosis is very good as long as metastasis has not occurred. The hallmark is elevated TG levels. The treatment is a total thyroidectomy, and these patients will also be on lifelong thyroid hormone therapy. And remember, with any type of thyroid hormone therapy, they need to take it at the same time every day on an empty stomach.